Buonasera.
Good afternoon, everybody, and welcome to all those who are connected with our session of the Rimini meeting that goes under the title Life, a Mystery. This is a very challenging title, and we are going to analyze this title and explain the content of this title thanks to the contribution of our three guests, whom I would like to thank for their participation. I'm going to introduce them briefly. These three guests, each for their respective area of expertise, have extensive national and international skills. So my introduction is only limited compared to their expertise. So we have with us Professor Theo Boer, whom I would like to thank very much for being with us. He is Professor of Healthcare Ethics at Kampen Theological University and chairs the Bioethics and Biotechnology Committee of the Conference of European Churches. He's also head of the Dutch and Belgian research groups in theological ethics. So thank you, Professor Boer, for being with us. Then together with us, we have Professor Antonio Pesenti, whom I will then ask to join me here on the stage. He also carries extensive responsibilities. He's the director of the Department of Anesthesia and Resuscitation of the Polyclinic University in Milan, full professor and specialty professor of anesthesia and resuscitation at University of Milan and University Milano Bicocca. And then, last but not least, we have Professor Elvira Parravicini, our dear friend Elvira Parravicini, who's a neonatologist, and she's the director of the Neonatal Comfort Care Program. I think she's held this mandate since 2008, and she's Associate Professor of Pediatrics at Columbia University Medical Center in New York, which is one of the most prestigious U.S. universities. So once again, thanks to Elvira for being with us. Very briefly, I would like to explain to our audience what these three outstanding guests have in common. What they have in common, in my opinion, is a methodological approach which is based on experiencing reality. In other words, in their professional life, they have often faced needs. They have dealt with needs that they tried to meet with treatment and care, but actually they saw what was taking place, they assessed what was taking place, and I think that one of the most interesting evaluations and definitions of intelligence is basically judging what you have to deal with, but actually in a critical way. And these three outstanding guests basically did that. They looked at the need they were meeting, and they tried and developed their own way of meeting that specific need. So if you're dealing with a human limit, you have basically to, in a way, meet that limit with someone who's capable of, in a way, understanding it in their own way, trying to give your own answers. However, in a plural world, you may have many different answers, and each and any one of us, in our own professional and human pathway, we can all realize that you may actually provide an answer, that you may provide a solution, and that solution might not necessarily exactly be the right one for that specific need. So these guests have this thing in common. They were faced with the need of someone else. They tried to provide their own answer, and then they checked whether that answer, that solution they gave to that need was adequate to that specific need. So I'm not going to spend additional words on this. The first contribution is by Professor Theo Boer, whom I would like to greet once again. Let me just add a couple of words on Professor Boer. For 10 years, and Professor, please correct me if I am wrong. For 10 years, Professor Boer was a member of the Dutch Commission for the authorization of the euthanasia authorization. So he was a member of the Regional Review Committee for Euthanasia. This was considered a last resort solution for very special cases with very severe and strict limits. However, looking at data, he realized that the last resort solution, that this had become a default way to die. So from being a last resort solution, that had become a last way to die. Then, of course, Professor Boer will explain better this. And so because of this, he decided to resign from this committee. He wrote a very interesting report, and this report was given to me by some friends of mine, was really fascinating because of the intellectual honesty that clearly emerged from the report. That is why I invited him to come to the meeting today. In these periods, what we are experiencing here is some kind of a blended meeting, but this is due to unexpected circumstances. And that is why I would like now to leave the floor to Professor Boer so that he can tell us how he experienced this very difficult period of his professional life as well as of his own personal life, because I think that this has had also repercussions on his personal life. Thank you.
Thank you very much. Thank you very much, and thank you for having me. The Netherlands was the first country in the world to legalize euthanasia. And I would like to do the following in the coming 12 to 15 minutes. I will look at just a little bit of the history of 50 years of euthanasia in the Netherlands. I will look at the rising numbers. I will address the question whether euthanasia will lower the numbers of violent suicides. I will look at how physicians experience euthanasia. And I will look at some other developments, because the big question here is, can we ever obtain a euthanasia law that fulfills its original purpose? And then I will propose some reflections. This is the starting point of the Dutch euthanasia discussion. It was a 1969 book published by Van den Berg. He wrote this very intriguing book, Medical Power and Medical Ethics, and Van den Berg argued that physicians, by treating patients, add to them misery and should then not stop treatment but kill a patient if necessary. He had heartbreaking pictures of people who were suffering. Here you see two of them. The person to the right is a man who's with a total body amputation, heartbreaking suffering. That was the beginning of the euthanasia discussion in the Netherlands. Now you see in this slide, you see the history, basically the timeline. You see 1969, Van den Berg's book. In 1972, the Dutch Voluntary Euthanasia Association was funded. It was important because they put the stress on the fact that they had to have voluntary euthanasia only. In 1985, euthanasia was officially tolerated, and even Protestant churches in the Netherlands actually condoned euthanasia. Not in all circumstances, but certainly they condoned it. Then in 1994 there was a makeshift law which resulted in 2002 in a definitive law. Now, very important for your understanding that a Dutch person that talks about euthanasia, he or she only talks about active killing of a patient at their request by a doctor. So it is not passive. One is not just free. There must be the request of the patient, and there must be a doctor. Sometimes in other countries there is a refraining from medical treatment that is supposed to be euthanasia. That's not the case in the Netherlands. Very important also, if I use the term euthanasia, I have about 6,000 to 7,000 cases per year, and this includes both euthanasia and physician-assisted suicide. What you see, it's only 3% of the cases. So most patients, very important, they prefer the doctor performing it for them. What are the criteria in the Netherlands? The criteria you can see here are 6 criteria. The first is a medical diagnosis, so you cannot have a euthanasia without being severely ill. The second should be the patient request, otherwise you cannot speak about euthanasia. Thirdly, there should be unbearable suffering. Fourth, there should be no prospect of improvement. If there is a prospect that things will go better, you cannot have euthanasia. A very important item is that you have to be terminally ill to have euthanasia. This is what I call a shadow criteria, because at the beginning it was not officially accepted as a criterion, it was actually functioning as a criterion. No euthanasia without being terminally ill. It means that your life should be still about 2 to 4 weeks. And a very important item is that there is an opt-out option for both individual doctors and for institutions. In Canada, for example, some doctors are considered to have an obligation to perform euthanasia. In the Netherlands, doctors do not have that obligation. I was part of this system, as your chairman said. I have much criticism about the whole situation, but this is a good system of monitoring. First, it includes scan doctors. It means that support euthanasia, support patient euthanasia Netherlands. It means that there is a second doctor that gives an opinion before judging whether the criteria are complied with or not. Then there is a regional review committee, of which I was part, which look at each case of euthanasia and then see whether they comply with the legal criteria. There is a legal requirement that there is a 5-year evaluation. After 5 years, we have a governmental report that says what is the development, what are the developments, and what are the developments. I would like to first show you some figures about the pathologies. There are 2 pie charts here with numbers. The one is from 2002 and the other one from 2019. As you can see, in 2002, we had 1,800 cases, most of which you can see in blue were cancer cases. There were some other cases, but a big part was about cancer. If you go to the lower picture, you see that Cancer still has a large part, but there are many other reasons behind it. And very importantly, there are psychiatry, there is dementia, there is age-related diseases. And then we have not very many, but we have seen cases with people with handicap, people who had autism, or people with a condition in the ear, with a terrible noise in the ear. So the number in 2019 were 6,300, and it's an enormous number if you reckon that it is about 4.5% of all deaths. I will go into that a little bit later, but one very important argument behind euthanasia is that if you give people the possibility to have euthanasia, the suicide numbers will go down. But it's actually, we have seen a revert trend. In the past 10 years, euthanasia has gone up by 150%. And instead of these suicide numbers going downwards, they went up by 35%. In all neighboring countries, suicide numbers went down. For example, in Germany, which has about a country with the same the region, with the people with about the same age as the people in the Netherlands. In Germany, the number of suicide went down 10%.
Whereas in the same period, the numbers of euthanasia, the numbers of suicide in the Netherlands went up 35%. So how can that be? And the director of the Central Bureau of Statistics, Jan Latten, suggested that he said there is much public discussion about ending your life and people will tend to act accordingly. In other words, there is an atmosphere of killing. There's an atmosphere that death is the solution to all your problems. We have now reached a culture in which for many people, I wouldn't say all, but for many people, death is the solution to any form of unbearable suffering. So do not believe the argument that euthanasia will keep the numbers of suicide down. It will most probably bring them up. One other important thing is the physicians, and that gives me some hope. Dutch physicians have become more hesitant. The number of physicians who will never do euthanasia went up by about doubled, which means that more and more physicians think that this is not the way to do it. And then 2/3 of the physicians in the Netherlands experience pressure, emotional and familiar pressure, and they say that the public underestimates the severity of this pressure. Very importantly, I think actually that the Netherlands, if we had the level of palliative care now, in the 1980s that we have now, I think we may not even have legalized euthanasia. There is an excellent system of palliative care in the Netherlands, but people simply, they want first palliative care and then they want euthanasia on top of it. So that gives me reason to believe that euthanasia is not about pain. It is about something else. It is about despair. It is about meaninglessness. It is about care dependence. And I have a friend who is a physician and he does euthanasia regularly. And he says, if I am ever to have spread cancer, I prefer to have palliative treatment outside the Netherlands. That is because he thinks that in a country where there is no euthanasia, physicians will do their utmost to make the patient comfortable. Whether in the Netherlands, a physician may say, well, we have euthanasia, so why shouldn't we resort to euthanasia instead? Now, I'm coming to almost my last dia. Some other developments that I think are discomforting. First, there is, as you can have seen in the other dia, there's an extension of euthanasia from terminally ill to all illnesses, including euthanasia, including dementia, psychiatry, and other chronic illnesses. Secondly, euthanasia is becoming from an exception. For many people, it's becoming a default way to die. It is their way to die, irrespective of the question whether there is good palliative care. I have done some research and I found that in some districts in the Netherlands, 12% of deaths were the result of euthanasia. And that means that it may be up to 25% if you only count the foreseeable deaths. And then there are some examples of other developments that I find discomforting. First, we have a new law proposal that says that anyone over 75 can have euthanasia, irrespective of their illness. Secondly, you can see in Canada that originally they had a foreseeable death as a criterion. And now they have given up the foreseeable death and they say that anyone with an illness can have euthanasia. Thirdly, we have since 2019, we have powerful advocacy for child euthanasia in the Netherlands. Fourthly, in June 2019, the 15-day waiting period in Oregon was taken away. And fifthly, in just a couple of months ago, a doctor was acquitted who had performed euthanasia on a struggling dementia patient who actually didn't want to be injected. But she had an advance directive, and they thought that this was what she would have wanted, but she resisted. Now, to stop and to conclude, I think that it is now a fact that those who maintain that my concerns are scaremongering, they are wrong. They may just as well not believe in climate change. I think that there is a slippery slope. I think actually that the euthanasia changes the way we deal with death and tragedy in a similar way like tourism changes the way we see the world. I think that supply will create demand. So if you legalize euthanasia, you will see not only that people will be happy to have euthanasia, but you will see other people finding that an attractive new development that they will feel attracted to. So there is absolutely no question if an Italian or any euthanasia law will be extended once it will be legal. It is only a question when that will happen. And I think that is a very important lesson to be learned. Thank you very much.
Scusate, stavo per applaudire.
I apologize. I was about to applause. I apologize. I was about to applause. I was about to make an applause because I think there is nothing to add to that. That's impressive. That's really impressive. You have provided us with clear data, and through this very clear data, it is legitimate to make a forecast. Maybe at the end I will make some remarks if we still have time. Now we have with us Professor Antonio Pesenti, who had to deal with another human need which exploded, which boomed, as in the need coming out of the pandemic. So he was the one organizing the network of anesthesia and reanimation units in Lombardy.
Vogliamo dirlo proprio basicamente, trovare
To find as many beds as possible during the emergency,
possibile, valutate situazioni
so that
nelle quali fosse appropriato l'invio a una rianimazione ne rimanessero fuori.
fewer people couldn't get into an ICU, into an intensive care unit, so as to guarantee as many beds as possible. Rather than making a priori category, he tried to find another solution. In any case, I will now give the floor to Professor Pesenti to come here on stage with me. Thank you very much for traveling to be with us today. A short journey, indeed. Thank you very much. I'm really very happy to be here. I don't have much time, and therefore I will immediately start with my presentation. What happened in Italy? First of all, we know that in Italy we have had almost 36,000 deaths for COVID. We also know that the people dying for COVID account for 1 to 2% of people who were infected, which means that in Italy we had 36,000 deaths and therefore 1.8 million people who were infected. In Lombardy, at the end of the day, we had about 17,000 people who died, accounting for 8.5% of the population who got infected. In some areas, for example, in the area of Bergamo, where I was born, almost 40% of the population got in contact with the virus, and there's many reasons for that. I won't dwell upon that, but that's an important problem to consider. We, people, physicians working in the reanimation and intensive care units, knew mid-January, through information coming from our Chinese colleagues, that the system of intensive care units would be highly stressed. Some forecasts at that time, in January, made us think that we would need thousands of beds in intensive care units. So, according to the dissemination of the virus in Italy, we would have had 5,000 to 10,000 patients, up to tens of hundreds of patients. Therefore, we needed to create a coordination system. Lombardy was the most affected region, and at the beginning of the pandemic, we had 720 beds in intensive care units overall throughout the region, where we also had patients with other conditions. If you look at this curve, starting on the 24th of February, you see that actually you have two curves, the red one, the orange one, and the yellow one. The orange one is the number of beds available in intensive care units. In yellow, you see the number of people ill in intensive care units. In week 1, we had 200, 300 patients. After that, the number of patients increased up to 100, 120 a day. Now, you understand that with the 720 beds overall, it was very difficult to find a bed for all patients. Therefore, we decided to dedicate some intensive care units to COVID patients. We couldn't isolate them. Therefore, we all grouped them into some intensive care units, and they were totally isolated. That was cohort isolation. But beds wouldn't be enough. So every day we would ask for more beds, or we would build new intensive care units for COVID patients, even in corridors, even in surgery rooms. And we had up to 1,400, more than 1,400 COVID patients at the same time. We transferred some patients to other regions, to Germany, and then at last, in early April, the number of patients started to decrease. During the emergency, we certainly had some problems where beds would never be enough, and definitely in some cases, we had to do some triage on patients because there was a lack of resources. We had poor resources, but this poverty of resources is very different from the poor resources you have during an earthquake or a bomb or a criminal attack. In that case, everything stops after a few minutes, and you immediately see what you have all at the same time, whereas here the emergency never stops and continues day by day. While during a catastrophe you have some rules, you choose the patient who at that time is more likely to survive. Here we also have another problem, as in if today we use a bed, we know that maybe in 10 minutes there's another patient coming who would have more benefits if he had this bed, because patients continue to arrive like 50, 60, 70 a day. At that time, I didn't have time to think, honestly. The Italian Reanimation and Anesthesiology Association at some point told us that we could have adopted a utilitarian, so to speak, approach, although we didn't use it too much, I have to say. As in, to allocate intensive care units to those patients who would benefit the most. Clearly, there's different approaches to this problem. And there's a typical example from Talmud saying that two people can have a bottle of water in the middle of the desert and none of them can survive with half a bottle. And what is the right thing to do if there's only one bottle of water and you would need 2 bottles of water? What is the right thing to do? Well, that's difficult. The decision is difficult. I'm not an ethicist, so I would rather neglect that aspect of the situation. Someone in the United States suggested to allocate resources with a bingo at random, by lottery. Well, we tried to follow the most logical guidelines, utilitarian guidelines, when it was necessary, which is what we usually do in our job, because we don't always put in intensive care units all patients who are about to die, but only those who can benefit from intensive care units. Sometimes a patient who is very old and maybe has other conditions and has lung problems, maybe does not have a lot of possibilities to survive, and therefore you need to decide that maybe intensive care units are not necessary. We even thought about using a ventilator for 2 patients, 1 for 2. It doesn't work pretty well, we know that, and that solution has never been used in this emergency. And then there's what you can see in these pictures. These are the famous trucks coming out of the city of Bergamo, carrying the coffins to be burned. So, the isolation of the infected patient. This situation had never been seen before. There were patients who went to hospital, no longer had contacts and relations with their families. Their families knew by phone what was happening. Patients in Bergamo were carried elsewhere to be burned, and sometimes the families wouldn't even know, where they had been carried to be burned. We could use technologies, iPad, cell phones, to ensure a relationship between patients and the families. And I was struck, honestly, by the enormous solidarity of donors, volunteers. I really think that donors and volunteers really helped us a lot in this situation. Another problem I was really struck by was the ethical problem of science and research. Now, research and innovation in medicine cannot be done on newspapers or by newspapers. You can't write in a newspaper that there's a drug that can save people's life, and then I'm a criminal if I'm not using it, whereas actually no one really knows whether that drug is good or bad for the patients. And many newspapers have done that. You need to continue using this scientific approach and methodology even during the pandemics. You can experience everything, but there's an ethics of science and an ethics of communication. You need to refrain from using slogans when you don't know what to say. Last but not least, let's remember that epidemic diseases, and I've seen myself Ebola in Africa, is a problem of public health. Intensive care units are not the remedy for the lack of public policies, of public health policies. Over the past 40 years, we have thought that infectious diseases were no longer a problem. We have decided that privacy is the most important thing in health. We have decided that some patients no longer have to be treated in a certain way, that children with lice can still go to school. So we have changed our approach. The first thing of infectious diseases, the first remedy, is isolation. Therefore, we need to set up a system starting to treat patients before hospitals. Patients must be treated before they go to hospital. And in my opinion, this is something we're not doing today. We have major hospitals, but we need to focus on primary care at local level. And primary care at a local level needs to be redesigned. And with that, I'm done. Thank you very much. Now, there's passionate research for proper solutions on a case-by-case basis, like using one ventilator for 2 people, or nurses that were not just following 2 patients but 3 new spaces. So great inventiveness, so that triage would be done on the individual and not on categories of people. Now, we have with us Professor Parravicini. She is the worldwide, I would say, founder of the Comfort Care. Someone of you maybe is already familiar with that word. It is interesting to understand why a neonatologist whose mission is to give birth to babies who are well and will have a good performance, at some point in his or professional life finds out that there is also some other children, some other families, and some other needs, and decides that they also have to be taken care of. I give you the floor, Elvira.
Thank you very much. Thanks to you all. Actually, I feel a little bit like Mickey Mouse after having heard the contributions by the 2 previous speakers, but I'm very happy that I am with you today and I can tell you a little bit about what I do. I would like to start by saying that I have always been attracted to treatments addressed to babies. And there are 2 reasons why actually children of this age, of this very young age, are so attractive. First of all, because this is basically the moment in life where you have basically all of your life ahead of you, and everything can happen from that moment. Second, and this is what actually strikes me a lot from babies, is that they completely depend on you. And this is something that really interests me very much, because I always think actually what babies do if they really kind of were aware of what the choices made on them mean, but at the same time I also think what we as adults, and if we as adults are aware of what we sometimes do on them. So this issue of conscience. So this is why I studied medicine. I became a neonatologist, and I've always tried to save the life of these young babies. I've always fought my battles, and the few times that I failed, in other words, that I didn't succeed in curing my patient, I actually was very sad, although I basically attempted. A major step in my life was when I moved to New York in December 1984. Actually, I went from the small intensive care unit of the hospital of Monza with a limited number of beds in a big intensive care unit of 60 to 80 beds, and the babies hospitalized there are much smaller than the ones I would treat in Italy. And so at a given point I wondered what to do if a baby is born too early and I cannot save him or her, or if that baby has a pathology that medicine cannot cure. And actually I understood that I never wanted to say there's nothing else to do, there's nothing else that I can do any longer. And there are 2 stances vis-a-vis these situations. You, on the one hand, have doctors that insist on treating the patients even if they are aware of the fact that patients will die. And that's terrible, because actually the patient dies, eventually always dies, but still you continue healing them. And then the other stance is is when you have doctors who decide that a life is no longer worth basically living, and so basically doctors decide that life has to stop there, and they do so by denying nutrition or administering drugs. And actually, I decided that I didn't want to adopt neither of the two stances, because it does not depend on us. We cannot decide when our life begins, and therefore we cannot decide when our life ends, and we cannot make that same decision on the others. So if life is given to us, we simply have to follow life. When I see my patients, I not only see them, so babies of, let's say, babies weighing 500 grams, but actually I am saying two loving arms bringing that baby to me, who brought that baby into life. So me as a doctor, what I can do is actually to follow the course of life of these babies and respect the fact that that life is given to them. And so the criterion of my medical treatment is that if medicine cannot save them, at least they should adopt their natural life. And I like very much this position because it respects nature, and it is dramatic, it is adventurous, because I mean, you're called upon to follow the patient. You know where you start, but you don't know where you will end up. My contribution is my medical skills, my medical knowledge, but that patient becomes my guide. And that is how the adventure of comfort care started. I didn't have any previously set guidelines, but what I had clear in mind was that I wanted to offer them a solution of treatment that would respect their course of life. And so I proposed solutions that I deemed appropriate to this concept. In other words, for example, how can a baby taste life? Of course, he or she can taste life by being with his or her family, by not starving, and by basically receiving drugs if he needs them. If you have babies with a short life, they are brought to intensive care unit. Maybe you're not doing anything, but they are maybe set in an incubator, and parents can be there. But that's not an ideal solution, because you may have a mother who has already given birth to his or her child. So where's the hug of the family? So actually, the idea was that, for example, the babies could be in the same bed of their with their mother. When I launched this idea, I had a lot of objections. I mean, the objections were, who is going to heal that baby? So lots of resistance, lots of objections. And to counter these objections, I was with them. In the first case was the case of a baby in which the baby was born, and I basically went the whole day with the nurse, the mother, and the baby, explaining the doctor that we could, for example, administer certain types of treatment, the kangaroo care, for example, or certain types of treatments. So the same applies to nutrition, to feeding the baby. Some babies find actually sucking the milk from their mother is basically the only joy in their life. I believe that my program is the only one in the world that also has a feeding specialist, which is a professional profile that basically assesses the ability of these young children, of these babies, to suck milk, to be fed. So everything has to be done in a safe manner. However, the person works with me and supports the babies of just a couple of days of age, and she or he helps them be fed. So gradually I developed guidelines, and I found along the way other professional profiles who were fascinated by what I was proposing and came and worked with me. So from this point of view, my program basically started from the opposite way. I mean, in a way that was completely different way than normal projects are created. I knew what I wanted to do, and I started with my resources in terms of time and professional expertise. And then over time, resources in terms of personnel and financial resources came. And this happened because I learned from babies, and I kept myself open to the promise. I didn't close the door. I mean, everything was given to me. And now you will understand why, for example, at a given stage, an intensive care unit nurse wanted to work with me At a given point, I received a donation by a foundation to pay the salary for 3 years for that nurse. And so I offered her the job, and so she left her job in the intensive care unit after 30 years she had worked there to come and work with me for just 3 years. That was a brave choice, but she was highly motivated because she feels what I also feel. And then things actually went well, so she continued working with me also after the 3 years. Then other donors came, and over the last 5 years, we had donations worth of $1.5 million. So I could hire the nurse, a social worker, and a manager. And I can pay their salaries every year. But again, everything is given. I'm not going to go into the details, but everything is given, and these donations came by themselves. So at the moment, my program is an integral part of the Columbia University Medical Center, but it is financially independent, which means that those who work for my program are chosen by me. And this is very important because mine is a special program. In America, you have over 200 centers offering palliative care, prenatal, natal palliative care, but my program is different. We have a different vision. What we'd like to do is that this life-respecting approach that reassures and comforts babies and families is applied all over the world to all families who have babies with such difficult problems. And so we embarked on education. We've always organized courses for doctors and nurses over the years, and last year we had an international course that saw the participation of professionals coming from 19 US states, as well as professionals from England, Italy, Australia, Burundi, and Russia. So COVID-19 is not going to stop us. And so now we are working to launch a permanent video course that is accredited for education, again, to spread and launch this approach to the whole world. So by way of conclusion, I would like to tell you the story of one of these babies to try and show you what it means that we try and follow the destiny of the patient in his or her natural life rather than imposing what we want. This baby was, this baby's name is Samuel. He's had trisomy 18, so a genetic disease. His mother wanted this baby to live as long as possible. She was also very realistic. She knew that he would have a very short life. So we often talked during pregnancy, and she told me that she didn't want to have any resuscitation. She didn't want to have intensive care unit hospitalization. She wanted to keep Samuel with her and leave Samuel to live and let Samuel live for what he was destined to live, which is at the very heart of what we propose to these parents. This family was a Jewish family, a very religious one, with the other 6 children. Then for them it was very important that the kid could be sort of introduced to the rest of the family. When the baby was born well. I mean, he would breathe, very nice, very small. He would weigh only 1.8 kilograms, but very lively. So we were very happy when he was born, because he was there, and that was the most important thing of all. There was a moment of joy and glory, as is the case in these cases. After a couple of hours, we then moved the mother and the kid and the rest of the family in the postpartum area. And during the physical examination, I understand that there was a complication. I suspected that he would have another condition. I carried out a very quick test that confirmed that the esophagus of this baby was not formed, and this complicated the situation because it was very difficult to feed the baby. We had 2 alternatives: the intensive care unit, or basically having the baby starve. And none of the 2 options was appealing to me. I also talked about this with the family, and they were also. They didn't know what to do because both solutions were horrible solutions. So I requested the advice of the surgeon, asking for a palliative intervention, but my surgeon was very worried because actually the baby had a congenital heart failure, very severe heart failure, and so the baby could die in the operating theater, and we could basically run the risk of shortening his life. So we kept on discussing, and while we were discussing, there was a young nurse working with me who took the initiative and said, for the time, she said this actually, we're still alive now. Let's live the present times. So we bathed the baby because it was very important for the mother to actually bathe the baby. So she took all the things that was necessary for the bath. There was a wonderful experience. I mean, the rest of the family was there. They would play with water and the baby. There was the perfect moment. I mean, everything was perfect. And I was observing what they were doing. And I understood, yeah, actually, my nurse is right. We should now live the present moment. We should follow Samuel and the reality. That's the only thing to do. And actually, I could not imagine what would have happened a couple of minutes later. While Samuel was being bathed and hugged by his mother, I saw that his face changed color, that he was no longer breathing, that he was sleeping. And so the mother basically understood that the moment of his departure had come, that she should talk to him. And in a couple of minutes, actually, his heart stopped beating. I didn't expect it. I mean, we were all desperate to understand what to do. We could not envisage a solution. But the baby already had a solution. He took the initiative. He went. Actually got lost himself in those loving arms that wanted to bring him to life. So once again, my patient, guided him. I would like to underline that this is no exception. This is just one of the many examples that I experienced during my work when I watch these young babies with great attention, and I expect everything from them. And I mean, each and every time it is like that. I could write a book on this. It's always a surprise, and you only have to follow. So the bath of Samuel that lasts forever. Then the figures given to us by Theo and his resigning from the committee are also forever. Then the research by Antonio are also forever. So taking care of reality and becoming amazed of reality becomes the only way that we have to become the signs of the sublime. This way, decisions are based on facts and not on ideas. Thank you very much for your participation and for your 3 examples. Thank you very much.
Ciao, arrivederci. Ciao.